Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities. The Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community.
Hello everyone, and welcome to Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your host for the next hour. Spark Live is where we gather each Wednesday to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community, with our goal to spark conversation, ideas, and action. Since we're live, I want to remind you that while we don't take questions over the line, you all have the opportunity to type your questions into the question box at any time. And we'll take those, we'll offer those questions up to Wendy, our speaker, at the end of the presentation. But go ahead and put them in as you think of them, and then we'll address them at the end. I'd also like to let you know about an event Children's Healthcare Canada is hosting in partnership with Alberta Children's Hospital and Alberta Health Services, being held in Calgary on April 22nd. This specialized event, called All In, Creating Synergy in Pediatric Complex Care in Canada, will welcome over 200 administrators, frontline clinicians, patients, and families. And the focus will be on showcasing and sharing practices that we know are working to help children with complex healthcare needs and their families. Registration is now open, and we're monitoring the COVID situation very carefully. Currently, the event is still taking place, and we'll keep you updated as any decisions are made. Today, with support from Children's Healthcare Canada's partner, the Child Bright Network, we will be talking about economic evaluation in child health, autism spectrum disorder. With rapidly rising healthcare expenditures, Canadian provincial government decision makers increasingly rely on cost-effectiveness evidence to judge the value of emerging treatments and technologies, to facilitate budget allocation decisions. At the same time, many provinces are instituting reforms in their subsidized autism spectrum disorder programs. Economic evaluations that compare alternative treatments to ASD diagnosis and treatment is essential to ensure that children and families receive the most efficacious services within health education and other public sector systems that face budget constraints. The Child Bright Network is an innovative pan-Canadian network headquartered at the Research Institute of McGill University Health Centre, co-directed by investigators at BC Children's Hospital and the Hospital for Sick Children, and funded by the Canadian Institutes of Health Research under Canada's Strategy for Patient-Oriented Research, or SPORE. I'm delighted to welcome our speaker today. Dr. Wendy Unger is a senior scientist in child health evaluative science at the Hospital for Sick Children's Research Institute, and she's a professor in the Institute of Health Policy, Management and Evaluation at the University of Toronto. Wendy leads a program of research applying economic evaluation methods to child health, with a current focus on genomics and neurodevelopmental disorders. For those of you on Twitter, please tag us at ChildHealthCan and at ChildBrightNet for any webinar-related tweets today, and feel free to share away. And it's my pleasure now to pass the mic to Wendy.
Thanks very much, and I'm really grateful for this opportunity to speak to you today. So I hope that you can see my slides on one screen as opposed to the two screens that are in my office. And it's a wonderful organization, so I'm very happy to have this opportunity. So as mentioned, I'm going to be talking to you about economic evaluation in child health. It's mainly an instructional type of lecture to introduce you to the concepts of economic evaluation with a focus on autism spectrum disorder. So we're going to start with the fundamental economic problem that we face, and then understand how we can apply economic evaluation to address that problem. I'm going to illustrate the principles of economic evaluation using a research study that's coming out of my research team. We published this a couple of years ago. This was a cost-effectiveness analysis of genome and exome sequencing in children diagnosed with autism spectrum disorder. So both this concept of sequencing and also, of course, growing interest in autism makes this research of particular importance. And finally, we'll spend a minute thinking about how cost-effectiveness evidence can be used in the most expedient way possible to make sound policy and funding decisions. So this is our fundamental economic problem. This is a graph showing the annual healthcare expenditures. It happens to be the province of Ontario. Year over year increases despite attempts to cap expenditures or even reduce them. Expenditures continue to grow. And you could probably replicate this slide in every province in Canada. And you can see that at least projected for 2019-2020, expenditures will exceed $60 billion for the province of Ontario, with an average annual year-over-year growth between around 2 and 4%. So this is a common story, and this is really what's motivating us to think about how we can spend our budgets in the most economic or most efficient way possible. So we understand health budgets are fixed, or we attempt to keep them fixed, and we have a finite amount of health resources available, a finite amount of physicians, services, hospitals, and other types of healthcare resources that we allocate to provide health services to our population. So all of these different treatments, interventions, programs right across the spectrum, they're all competing for those same scarce healthcare dollars. And that means that we have to make a choice. And we want to make a choice that is as wise and as efficient as possible, such that we don't waste any of those precious resources. We want to choose such that we're maximizing our output, in other words, our health gains, for every dollar that we invest. It really is this concept of value for money, bang for the buck. And you know, there's a lot of concern about rising healthcare expenditures. It's eating up perhaps a third of our GDP within each province, and that means every dollar becomes more and more precious. So we really want to make sure we're spending the money wisely. The simplest way to think about economic evaluations, I like this slide because it's a very simple definition. It's a comparison of two or more alternative treatments or technology, both in terms of costs, the healthcare resources that we consume as patients, as citizens, weighed against the health improvements that we expect to see as a result of this investment in health or this consumption of resources. So it's always this idea of weighing costs, weighing consumption against health benefits. And obviously you want to tip the scales so that you are seeing a great deal of improvement in health and not a lot of healthcare expenditures. So taking our attention over to autism spectrum disorder, I like this slide because it's a simple depiction of the idea that, in fact, it is a spectrum disorder. There's a wide array of different types of social, communication and behavioral effects that really characterize autism. Children are presenting with very different ranges of these types of effects, and there's really not a lot of consistency among children. They really are unique. The other aspect, of course, to autism is that it's chronic. There are lifelong impacts, not just for the child, for the adult with autism, but of course for those families. And from my perspective as a health economist, it's interesting to me that this is a so-called health condition that really isn't treated in the health sector. This is a condition where we have to provide services and supports in the school sector, in the education sector, community services, child and youth services, and hopefully broad programs, agency programs that consider all of the different ministries that provide these services. This is a condition where early intervention can make a big difference, and these benefits can accrue over the lifetime. So these are the key characteristics of autism that are relevant for our talk today. So why do we want to do economic evaluation in autism? Well, the prevalence, latest estimate, is 1 in 88 children. It's very high, and there are concerns that, in fact, that incidence is increasing. We also know that the needs of children with autism are very complex. As I mentioned, no two children are alike. Autism is very heterogeneous, not only in how children present symptoms, but also a very wide array of services that are available and that are sought. So it is a complex condition on both the demand and the supply side, to sound like an economist. There's a lot of public pressure to expand and fund early intensive behavioral intervention programs. So these are the programs that are offered in the preschool years, in that very important developmental window for children between the ages of 2 and 4, as they expand their ability to speak, to interact socially, communicate, and function with others and interact with others. EIBI is a very costly program. It ranges between $45,000 to $90,000 per child per year, depending on how that program is structured. It may be a one-on-one program, depending on how many hours per week, depending on whether there are other, for example, language services that are part of the program. So it can be very, very costly. This is a range for a few of the provinces across Canada. Another aspect that's, I think, increasing the economic pressures on us to do a better job in this area are wait times. At least in the province of Ontario, families have to wait a long time at the very first step, which is if they're showing early signs of autism, their family doctor might refer them to a developmental pediatrician for assessment. There's a wait time just to see that pediatrician, to get that assessment, to get that clinical diagnosis. And once the child receives a diagnosis, there's another wait time just to get on the waiting list to receive that early intervention. So the idea of wait times creates a tremendous amount of economic pressure, because it means that people are not getting the services they need at the time that they need it. So that means we really need to think better about how to provide our services in a more efficient way. We want to allocate our very valuable dollars, our valuable services, in a way that doesn't cause any waste and that gets the services that are needed by the children who need it the most. And I'm sure you're all aware that there are many provinces right now that are in the process of introducing reforms to their autism programs. The community is very active in these discussions. And I believe that these reform discussions are best served by evidence that looks at the cost effectiveness, that looks at the value for money of alternative approaches to screening, to diagnosis, and to treatment to optimize that program delivery and maximize the health benefits for children and families. So here's a typical budget problem that an autism manager might face. They're doing their job well, they're going to increase their budget. So let's say they have an additional $1 million available to them. Great, how are they going to spend it? Well, they could think about spending it on additional special education supports in the schools. This is a problem that has been seen in many areas in public school systems where there are not enough special ed assistants for these children. Well, if we want to spend the $1 million there, we're only going to be able to afford 40 of them at a cost of $25,000 per child. What about whole genome sequencing, which will be the subject of my talk today, to aid in early diagnosis? Take a genetic test, get a diagnosis. Well, at $2,500 per test, okay, you can fund about 400 kids. What about an alternative to early intensive behavioral intervention that involves parents, a parent-mediated approach at $45,000 per child? Well, only 22 can be funded. What about respite services for parents? You know, parents are very involved. They feel a great deal of the impact of providing care for these children, and respite services are much in demand. Well, you could fund 1,000 of those. So you can see that $1 million is not going to go very far. And how do you make this decision? How do you decide to allocate the money? Where does it go? I can tell you it's not based on cost. It's based on cost effectiveness. And that's where we're going to go today and try to understand the principles of economic evaluation. So the example that I want to share with you is this study, as I mentioned, cost effectiveness of genome and exome sequencing in children with autism. Well, there's been tremendous amount of attention around genome sequencing these days. What is it that I'm talking about when I refer to genome sequencing? It's really two different types of tests. There's whole exome sequencing and whole genome sequencing. Whole exome sequencing is kind of an abbreviated form. It sequences the part of the genome that codes for proteins. Proteins are the molecular workhorses in your body that do a lot of the functional work, but it only comprises about 1% of the entire genome. Whole genome sequencing, like the name says, decodes your entire DNA content, the entire DNA structure. And what that means is whole genome sequencing could detect many different types of variants. So sometimes the variant is not a simple point mutation. It could be copy number variations and many other types of structural variations. So whole genome sequencing is the approach to get at all the different types of variations. And early work in autism has shown, in fact, there are literally hundreds of potential susceptible genes and many different types of variations in the genetic structure, in the DNA structure that are relevant to autism. All right, so this was our study. What is the rationale? Well, again, this idea that with a genomic test, maybe we can facilitate early diagnosis. And ideally, if we understand the variants that are identified well, maybe we can link them to specific autism deficits and even comorbid conditions like ADHD. This is where the research is going today, understanding that relationship between phenotype, the way a child presents individually their particular type of symptoms, and the variants, the genetic variants that explain that those types of deficits. And even better, hopefully one day soon, it's not happening yet, but we can even use that information to tailor treatment so that the child can get the kind of treatment that benefits them most. But it's really about early diagnosis. That's really the impetus of doing this type of test. So the two study objectives we had, one was to, of course, model the diagnostic care pathway. We're not talking about long-term treatment. This is really a circumscribed pathway where we're thinking about the best, most expedient way to diagnose autism in children. And of course, to measure the incremental costs and health consequences of doing whole genome and whole exome sequencing in that diagnostic pathway compared to some standard of care. And as I mentioned, economic evaluation is always about comparing something to something else. So typically we're comparing the new technology, the new intervention, to a standard, in this case, a chromosomal microarray. Microarray is the genetic test that's currently recommended by clinical practice guidelines in autism, and it's a very macroscopic look at the DNA. It doesn't get down to the types of variation that you see with sequencing. So in this slide, I share with you the basic elements of economic evaluation. You would see this in any type of economic evaluation. Firstly, the study design. Many economic evaluations are done through mathematical modeling. We create a microsimulation. In other words, we create a hypothetical cohort of children, and we imbue that cohort with classic clinical characteristics that represent autism by age, by sex. In this case, our target population would be preschoolers. We're talking about early diagnosis, so young children. We also think about clinical characteristics. So it's not unusual to conduct economic evaluations through these types of complex models. The next thing we have to do is stipulate a payer perspective. What are the costs that we care about? Who's the target decision maker for this economic evaluation? Whose desk am I going to be putting this evidence on? And even though, and I'm going to come back to this idea that autism is very multi-sectoral in terms of services we need to provide, when we talk about genome and exome sequencing, we are still within the realm of the public healthcare system. So for this particular study, we took two payer perspectives. We started with the public healthcare system, but we also took a broader societal perspective because there are relevant costs that are not captured within the healthcare system for this economic evaluation and for really all economic evaluations in child health. That requires one to take a broader societal perspective. And I'm going to get into this in a little bit more detail in a minute. The next part of any economic evaluation is, of course, stating what the important comparators are. So here's our standard of care, chromosomal microarray. As I mentioned, it's indicated in the clinical practice guidelines. The next comparator we wanted to look at was a combination of microarray followed by exome sequencing. So this would be a serial testing strategy whereby children who have a negative microarray, no findings, would then go on to an exome sequence. And these are children that are referred for testing because they are showing some signs and symptoms of potentially autism. So microarray followed by exome sequence. Another option might be to say, well, why don't we just replace microarray with exome sequencing as a first-tier test for everybody? And another alternative to that would be, well, why not just do genome sequencing as a first-tier test? So we chose our comparators very carefully, thinking about how they might be used in clinical practice. And we wanted to understand the relative costs and relative benefits of these different types of combinations, these different types of comparators. For every economic evaluation, you have to state a time horizon. For chronic conditions, we like to take a lifetime time horizon, but in this case, again, we're talking about a diagnostic intervention. So we took a fairly short time horizon, just 2 years from the time of clinical diagnosis. Finally, every economic evaluation requires a measure of effectiveness of the technology or the intervention that you are evaluating. Just like any type of clinical trial, you have to measure effectiveness. In this case, again, talking about a diagnostic test, so it makes sense to indicate the effectiveness measure as the number of children that you identify with that test, how successful you are at identifying children with a pathogenic variant. Because time or timing is so critical in autism, because the real rationale for doing genome sequencing is to get an early diagnosis, we put another condition on our outcome measure, and that was that we identify those children with a pathogenic variant within a fixed time period. In this case, within 18 months after diagnosis. So if you're sitting on a waiting list for 6 months just to see a medical geneticist, and then another 6 months just to get the results from your genome sequencing, and you've missed the window for early intervention, having a positive test result a year later isn't really helpful. So we wanted to replicate the way our healthcare system actually works and put this additional constraint of a fixed time interval onto our effectiveness outcome measure. All right, so how do we do costing? This is perhaps the more tedious part of economic evaluation, but you really get a good understanding of how the healthcare system works when you do this. There are 3 steps to costing for any economic evaluation, starting with item identification. What are the cost items that are relevant to your study? And choosing those items depends on your payer perspective. As I mentioned, if you're in the healthcare perspective or a public healthcare payer perspective, you're only going to choose items that are paid for by that perspective. Also relevant to identifying items is the time horizon. So for this study, again, we're in the diagnostic phase. We're not concerned with, for example, adult support services for adults with autism. We have a short time horizon here. So we're only concerned with resources that would make themselves known within that short time window. The next step is item measurement, and it consists of really 2 phases. One is identifying the volume of use for every particular cost item that's relevant to your study. That's how much, how many services, how many visits to a physician, how many sessions with a genetic counselor. The second part of that is price. We have to go out and find a unit price for every one of those cost items to apply to that volume of use. In the third step, cost evaluation, we put it all together. And I'm going to illustrate how we did that for this study. So here I want to get a little bit more into what I mean by study perspective, because it's quite relevant for any research in child health or any research in autism. As I mentioned, for our study, we're very focused here on the healthcare system perspective. This is the payer that pays for any kind of public healthcare services like physician visits. Here are the genetic tests, the lab tests. Health, of course, pays for emergency room visits, hospitalizations. But there's so many other sectors in the public realm that are relevant to autism. Obviously, the Ministry of Education that will pay for special education support workers and other types of school-based support. Child and Youth Services may be the ministry that pays for early intensive behavioral intervention. And yet other services within the public sector that perhaps there may be publicly available respite services and employment supports. So we have to think very broadly when we think about autism. And depending on your research question and all of the other aspects to study design, you may or may not include these other sectors. Another important payer perspective is the private payer. We can't delude ourselves into thinking we have this great universal public healthcare system when it won't cover medications. Now, for autism, that may or may not be a concern, although many children with autism do co-present with, for example, ADHD and do require prescription medications. But again, it depends on your research question and what's relevant to study. But we can't ignore the private payer as an important payer for specific analyses. Another very important perspective is the family. And in many of the economic evaluations that we do in autism, we administer questionnaires to families because we understand that they're going out and paying out of pocket for a lot of services. And if they happen to reside in a province where their child is sitting on a wait list, many of these families are not going to wait. They're going to go out and see what they can pay for. That isn't a government-sponsored program. So they're looking for early intervention. They're looking for behavioral intervention. So they're paying out of pocket quite a bit for uninsured services. They may also be paying quite a bit for travel if they don't live in urban areas, or if they live far from the site where they're receiving an early intervention. Something like genome sequencing is going to be concentrated usually in not only in urban centers, but in a medical a hospital affiliated with a medical school. So travel is often a consideration. Families may be paying out of pocket for medications if they don't have a drug plan, and they certainly might be facing co-payments if they do. So the family perspective is often a very relevant one. And all of these perspectives can be considered under the umbrella of society. A societal perspective is where you consider all the costs regardless of payer. And the reason it's so important to child health economic evaluation is because it's only the societal perspective that allows you to capture these indirect costs, which are time losses for persons with the condition or their caregivers. So because parents are so involved in the care of their children for autism or for other conditions, they quite often will lose time from work or lose time from other types of activities. And that's a true productivity cost that we want to capture. And you can only capture that if you take a societal perspective. So you'll see me taking a societal perspective in all of my economic evaluations. All right, so to get back to our study example, let's go through these steps of costing, starting with cost item identification. Now, it's a fairly circumscribed economic evaluation here. We are within the healthcare sector, and there are a few direct costs that are relevant. So here are the cost items. Clearly, genetic testing is relevant. All these different types of genetic testing, not just exome and genome sequencing in the microarray, but also Fragile X testing, which is often part of the equation for children referred for genetic testing. We're also concerned, of course, with genetic counseling that children will undergo pre and post test. And you can imagine that those counseling sessions, the length of the sessions or perhaps the frequency of sessions, will vary depending on which type of genetic testing they undergo. If there's a lot of information that could be gleaned potentially from a genetic test, there may be a requirement for more genetic counseling. These children will also be seen by medical geneticists, so we have to consider those types of costs as well. Okay, the other component, as I mentioned before, we're doing a societal perspective, so we need to think about those indirect costs, the productivity costs. So what do I mean exactly by that? Well, this would be absence from paid labor, so time lost from work, but also time lost from unpaid labor. So any kind of usual activities that parents might be engaged in, homemaking, taking care of other children, volunteering, they may be students, any type of usual activity, even though they may not be a member of the paid labor force, there's still a productivity loss, and we count those. And as I mentioned before, travel time could be considerable. That's a productivity loss as well. So we're interested in these indirect costs that are incurred by caregivers, in this case, caregivers for children with autism, because our study is focused on children receiving genomic testing. Okay, so next up, cost item measurement. All right, so for every cost item, we need to think about, as I mentioned before, the volume of use and the price. So where do we get this information? How do we find out how many sessions with a genetic counselor you need for each type of test? Well, if your economic evaluation is being done prospectively, for example, alongside a randomized controlled trial or as part of a larger observational study, you can make a point of collecting all that information through surveys and questionnaires. More often than not, though, particularly when you're building a mathematical model to do your analysis, you're going to get the utilization volume retrospectively from published studies. And that's what we did in this case. We looked at the published literature. If you're doing a very large study of health services utilization and you're interested in a wide range of services, a very good source for that information are administrative databases. These are the provincial databases, the provincial billing databases like OHIP in Ontario, that actually are used a great deal by health services researchers because it's a wonderful way to get at this information at a population level. You might also look at medical charts, of course, if you can rely on the data, if you know that they are that there's good capture of the information that you need. The prices, where do we get those? So again, as I mentioned, parents are often spending their own money out of pocket to access resources while they're waiting for provincial programs to kick in. So we ask them, what do you pay out of pocket for these different types of programs? For other types of services like physician services, it's actually quite easy to obtain the prices. These would be fees, and they are publicly available through fee schedules in every province in Canada. Other types of wages for non-physicians can also be available through institutional financial records and other sources. So we get pretty good at finding information around prices, but inevitably we have to collect some information prospectively for many of our studies. All right, the valuation step. How do we put all this together? It's pretty simple. When you break it down, you're just multiplying price times quantity for every cost item that you have. So the number of genetic sessions with a genetic counselor times the cost of each session. The number of, you might have the number of medical geneticist visits with a medical geneticist as well, the number of genetic tests, and so on. You simply multiply that by the cost of that item. For the productivity cost, the indirect costs, it's the time loss multiplied by some measure of wage. Now, in my research, I don't ask parents or participants their household income or their wages, in part because there's often a selection bias when you do research. The people that graciously give their time to contribute to research are not often representative of the full socioeconomic spectrum of our population. So it's very simple to use statistical wages. Stats Canada provides great data on average wages by age, by sex, and those are the wages that we use to multiply time losses. But we have to get the time losses through reports by parents, or we have to make some assumptions about time losses for example, the period that it takes to receive genetic testing and genetic counseling. The last part of that, of course, is the aggregation. Once we have information on volume of use and direct cost or price, we can determine the total cost per patient for every year of our study. When costs are deferred, when they occur in the future rather than the present day, we do apply a discount rate to future costs. It's usually somewhere between 1% and 3%. And that's because from a payer perspective, it's a good thing to be able to defer costs. So you want to kind of penalize the costs that are upfront compared to costs that you can defer. So it's traditional to apply some type of discount rate. For our study, we have a very short time horizon. It's only 2 years, so discounting is really not that relevant to our analysis. Then we want to calculate the average cost per child or per patient for each of our comparator groups, so we can start to make some comparisons. And often in economic evaluation, this is a point where you can think about what are the important subgroups. Maybe I want to look at average costs by age group or by sex or by gender. Maybe I want to understand how different categories of cost contribute to total cost. So how do the indirect costs compare as a percentage to the medical costs? So this is really quite flexible in being able to present the costs in different ways for your target decision maker. Let's get back to our example then. I'm going to start to show you some results. So as I mentioned, for every economic evaluation, you have to define your outcome measure. This is a diagnostic test, it's genome sequencing. So we're interested in the number of children that are identified with one or more pathogenic variants in a sample that's actually referred for testing. So this is a term that's called diagnostic yield. This is how the clinicians and laboratory directors refer to this, this estimate of effectiveness of a diagnostic test. They call it diagnostic yield, the proportion of persons referred for testing that actually show a positive finding. As I mentioned before, we impose this time constraint. So it's not good enough just to have a positive finding. It has to occur within 18 months of a clinical diagnosis, because it actually has to be useful to deciding what to do next and to put that child in the queue to receive the early intervention. With the genome sequencing, and this is some of the really fascinating elements of doing sequencing, is you can actually return a lot of results. There are the primary results. These are the ones related to your target condition like autism, and that list is growing very rapidly as we understand more and more about brain function and what might be related to the autism deficits that we see. There's also a list of secondary variants, and this list is also growing. These are variants that are not at all related to the target indication, to the autism, but they're specified as important to detect because they're related to other medical conditions that might be medically actionable or treatable. So there's a list put out by the American College of Medical Geneticists and Genomics. Right now, there are 59 variants on that list, and they relate to things like the BRCA1 gene for breast cancer, Lynch syndrome, particular types of epilepsy, cardiomyopathies. Unrelated, completely unrelated to autism, but nevertheless important to detect early because you can do something about it. So that's one of the great benefits of genome sequencing that people like me, health economists, are scrambling to be able to apply the method so that we can adequately capture those benefits properly. So here's a snapshot of our microsimulation model. I don't want to scare you with this diagram. It's just the idea to kind of convey to you how we do this. It's called a health state transition model, also known as a Markov model. These are our comparative groups over here, our 4 comparators, and these are the different states, so-called states, that they transition in. Pre-test, then they get the test, then there's post-test counseling. And in this model, we allow for every possible outcome of test results, positive or negative, both for primary and secondary findings. And for every pathway in our model, we ascribe costs. So we can understand the economic implications of every different possible combination of test result. It's a probabilistic model, which means that in our cohort of 1,000 children, we actually run the model repeatedly. We run it 1,000 times. So in our model, we have estimates, for example, the probability of a positive test result. But rather than just give a point probability, we'll assign a range because we're looking at the literature, and because these technologies, the exome and genome sequencing technologies, are still new, we're looking at multiple publications to understand what is the range of a positive result when you apply these tests to kids with autism. So by sampling 1,000 times and sampling from those ranges of values for each of our model inputs, we can have a fairly robust result based on the best possible evidence to date. So here is an example of a results table. This is how you would structure a results table for any type of economic evaluation. And this is from the societal perspective, the payer perspective. This is where we indicate our different strategies. Here are our 4 comparator groups. We have a column for costs, we have a column for effectiveness, in this case, diagnostic yield, and then we have the summary estimate. This is the incremental cost effectiveness ratio. So I'm going to walk you through this. Here's our reference. This is chromosomal microarray, our standard of care. And we find that the mean cost in this group is just over $1,000, $1,080. Now, this isn't the cost of microarray, it's the cost of that entire pathway of care. So it incorporates any kind of genetic counseling or visits to a medical geneticist. So that's our reference group, and our average yield, diagnostic yield for microarray is known to be 9%. The next comparator is the microarray followed by an exome sequence in the case of a negative microarray. That cost is more, it's about $1,300, but what's relevant to us is this column, the incremental cost. How much more does it cost over the standard of care? And that's about $222. And what do we get for that additional $222? Well, we get an additional 3.7% in diagnostic yield. It's 12.7 over 9%. We're able to get another 3.7% in yield. So when we take the ratio of the incremental cost to the incremental measure of effectiveness, that's where we get this incremental cost effectiveness ratio. And what this says is that it costs $6,000 to find one more child with a pathogenic variant if you were to replace microarray with this combination of microarray followed by exome sequence. Now, what if we were to do exome sequence instead of microarray? The incremental cost is $891. We have a gain of about 6.6% in yield. The incremental cost effectiveness is $13,504. If we were to replace microarray with genome sequencing as a first-tier test, this is the Cadillac of genetic testing. It's expensive. It's over $3,000. The incremental cost itself is over $2,000. We get a great bump in yield, almost 20% improvement over a microarray, and the incremental cost effectiveness is $10,785. So it's interesting, even though genome sequencing is known to be the most expensive, much more expensive than exome sequencing as a test, it's more cost effective because it's providing so much more in terms of yield. It's providing more information about pathogenic variants that are specifically relevant to autism. And what I want to draw your attention to, it's not the cost column that matters. I think too many people think about what does this cost versus what does that cost. That's not what's relevant to decision makers. It's this column. It's this incremental cost effectiveness. It's what does that incremental cost buy you in terms of added benefits. Again, this idea of weighing costs against improvements in health. And on face value, on the surface, these are big bucks. That's a lot of money to spend to find one more child with a positive finding. And is it worthwhile or not? That's part of the decision, the funding decision for the decision maker. What about uncertainty? So I said a minute ago that we try to use ranges for values in our probabilistic model. That's something that's actually important because in every economic evaluation, you have uncertainty. We may be taking our parameters, our model inputs from published studies, and there may be a range of values reported. So we have to be very clear about what assumptions we make when we use values for our probabilistic model. We have to be very transparent. We have to state all those assumptions explicitly. And we also do a lot of sensitivity analysis. We want to understand what are the implications of narrowing that time window. As I mentioned before, we have an 18-month window for finding a positive results. What if we narrowed it to 12 months or 6 months? That's where we do sensitivity analysis to understand the implications of making changes in key inputs to your economic model. You can change variables one at a time, or you can do it simultaneously, which is the way we did it through a probabilistic analysis. And that way, we're incorporating the uncertainty directly into our analysis, and we can add indicators of precision, which are things like a standard deviation or a confidence interval around our estimates. That's actually, in my mind, as important as the actual point estimate, is that range, that confidence interval, when you're reporting your result to a funding decision maker. Okay, so let's kind of recoup and think about our key findings. If you were to ask a clinician today about the value of genome sequencing, they're going to say, it's not going to make any difference. The interventions are behavioral. It might identify some comorbidities, but the reality is that the knowledge is evolving really rapidly about this relationship between known pathogenic variants in neurodevelopmental conditions and what they mean in terms of those behavioral deficits. There's a tremendous amount of attention being focused on this, and I believe that the day will come when we can actually use this information in a more meaningful way. Certainly, as that list of pathogenic variants grows, both in terms of primary and secondary, that means the diagnostic yield is growing, as well as the clinical utility or the clinical value of that technology. It's simply going to be a more useful technology for us. But on the flip side, of course, if you have a longer list of primary variants that are related to autism and secondary variants related to other things, that's going to increase the demand for testing, increase the wait time to see a medical geneticist to get the test. And then if there are positive findings, primary or secondary, now these children are going to be referred to other specialists, to oncologists, to cardiologists, and they're going to be monitored. So that can also increase health system costs. But if they're monitored and you do avert breast cancer or avert a cardiomyopathy, that's also a great benefit, and that has to be incorporated in your economic model. So you can see that it can actually get quite complex. So to kind of get back to my earlier point, we really believe that efficiency can be realized if you invest in interventions that can contribute to an early diagnosis, get the ball rolling as soon as possible to improve health, improve functional outcomes over the long term. And I also want to reiterate, although I'm focused on this somewhat kind of Cadillac technology or esoteric technology around genome sequencing, there are a lot of wonderful studies ongoing, some of which I'm involved with, that are looking at the cost effectiveness of alternative approaches to treatment, to early behavioral intervention, including very young children, toddlers, parent-mediated approaches as well. And I want to stress, in fact, the costs of autism don't actually lie in the preschool year. People are so attuned to high costs of early intervention. But the real costs of autism occur in the adult years. These are for individuals with autism who are very severely affected, who require social supports or even residential care for many, many, many years, literally for decades. That's where the real costs of autism occur. And if we can shift that curve just a little bit, if we can improve functional outcomes even slightly with early intervention such that we can increase the number of adults or the proportion of adults with autism that can, for example, participate in the workforce, we can make a huge difference. We really can. And let's remember all the other benefits, which we don't always do a good job of measuring. reducing the caregiver load, improving productivity, both for the caregiver, the parents, as well as the individuals with autism themselves. They can attend school more, pay more attention, improve quality of life for all family members, reducing the strain on all the other sectors, on the educational and the social service sectors. Finally, my last slide, I just want to give you an use this information. And we don't just focus on cost effectiveness evidence. And I say that because I'm actually a member, or I chair the Ontario Genetics Advisory Committee, which makes the funding decisions for the province of Ontario. So I sometimes wear this decision maker hat as well. So around the table at the Ministry of Health, when we consider what to fund, we consider a number of different criteria. First and foremost, does the technology work? What's the overall clinical benefit? Are there any safety concerns? What's the need in the population? Then we think about value for money, cost effectiveness, but we also think about cost to the system and the overall total budget impact. A very important consideration is consistency with social values. You can imagine that when you do genome sequencing, there are a number of really important ethical considerations. When you have a positive finding in a child, often the parent, the sibling, or other first or second degree blood relatives may be referred for testing. And you can imagine for some of even the secondary findings, now you're prompting individuals, your aunts, your cousin, to go for breast cancer screening or genetic testing to see if they're carrying that gene. There are a lot of ethical issues around consent. Do you want to divulge results related to adult onset conditions when a child is being tested? So there's a lot of people looking at these issues as well. Finally, what about feasibility of adoption? To bring something like whole genome sequencing into institutions like the Hospital for Sick Children is a major infrastructure and retooling investment. Labs have to be refurbished, and we have to train staff. There's a whole field of technical expertise related to bioinformatics that has to be grown in order to use this technology in a good way. So there's a lot of attention being paid to receptiveness of organizations and the feasibility of bringing this in. And to give you an example of a recent funding decision, in the fall, the province of Ontario made a positive funding recommendation for exome sequencing following microarray for unexplained developmental delay. This is the first positive funding recommendation for genome sequencing anywhere in Canada. Now, these are not children with autism. These are children who actually don't receive a clinical diagnosis of autism. They have some other cause for their developmental delay. And it was found that if you position exome sequencing after a negative microarray, you can actually save money to the system, because these are the types of kids that are on this long diagnostic odyssey. They may have some type of rare disease. They're getting test after test after test, and it's literally costing the system a lot. So if you can end that odyssey with an exome sequence or a genome sequence, that can actually be a very good thing. Now, that health technology assessment that was used as the evidence package to make that funding decision includes all of this other information. It looks at overall benefit. It looks at cost effectiveness. We commissioned an ethical analysis as part of that package. We also looked at the literature on patient preferences and on other stakeholder preferences like practitioners. And very importantly, a big part of that work was engaging directly with families. There was a direct patient engagement piece. And I also want to reiterate that the decision makers on the committee that made the funding decision, including the clinical experts, also includes a number of members that represent family groups from members of the public. So I am going to end there. Thank you for your attention. I just want to end by thanking all of the members of my team, my colleagues, my collaborators, and the various sources of funding for my autism research. And if you're interested in learning more, I encourage you to go onto my website, or you can listen to my 3-minute TED Talk about this topic. Thanks very much, and I'll turn it back over to the organizers.
Thank you, Wendy. We've got a couple of questions in the question box.
Great.
So Shirley asks, how is the standard of care delivered or factored into the output or quality within the EIBI amount of dollars?
Well, I don't know if that question refers to specifically standard of care with respect to genetic testing or just generally. So if you're doing an economic evaluation, you do have to make assumptions about defining standard of care. And that can be very challenging when the actual EIBI program varies from province to province. That's something that we're actually looking at right now, is what does EIBI mean and how is it defined? And the only way to understand that is to collect that information from provinces. So what we might do is have different types of standard of care. We don't have to fix it with one value. We might say, okay, we're going to describe the EIBI program as it's represented in the province of BC or Ontario or Nova Scotia. And then we're going to vary that to represent the other provinces. So we can have multiple standards of care so that we can then generate results that are informative to that particular provincial decision maker.
Thank you. Another question, and I encourage folks to enter any that you think about now. There's a couple of more that we'll go through, but it's now your time to ask what you need or want to know. The next question, how does this benefit after they have received a clinical diagnosis? Does this inform a more targeted intervention or choices?
Yeah, I knew someone was going to ask that question, so thank you. So one would think, well, if you have a clinical diagnosis, what good does it do to then add on genetic testing? And so in many jurisdictions right now, not everyone does the microarray, but it has been recommended as part of that assessment pathway. It in no way substitutes for a detailed assessment by a developmental pediatrician or a team that looks at the various functional abilities of the child. But this is the time, I think, where things are changing. So it's an add-on. It's understanding what those underlying genetic causes might be. It doesn't replace assessment or early diagnosis. You're still going to get that clinical diagnosis from a clinician. The hope is really that it'll just fast track things. That let's say you're waiting for the full assessment by a developmental pediatrician, but you can get a blood draw for the genetic test. And if it's positive, maybe you can get in the queue for the EIBI, even though you still haven't received your clinical diagnosis through the assessment. So it's just another piece of the puzzle. It's more information that hopefully can be used to fast track early intervention.
Wonderful. And our last question so far is, what is the established research saying that early intervention benefits kids with pathogenic variants as opposed to ASD-NOS?
So I'm sorry if I wasn't clear about that, but all children with autism will display some type of mutation or genetic variant that explains their autism. They're different though. There's a long list of variants. So some kids might have a particular type of variant and others will have something else. But everybody has some type of underlying genetic variant. So it's not kind of one or the other. I think what we're trying to really understand, and it's still very, very early days, is what a specific genetic variant says about function, says about ability to communicate, interact socially, develop cognitive skills. And these are very early days for that. I don't know if I answered the question exactly, but it's just to provide more information.
Thank you very much. There are no other questions in the question box. I really appreciate your time today, Wendy. This has been a fascinating presentation.
Great, my pleasure. Thank you so much for the invitation.
And we'll close out now. Thank everybody for their time, and for you, Wendy, again. Children's Healthcare Canada hosts our Spark Live webinar series every Wednesday at 11 a.m. Eastern. It's always great if you can watch live, as your questions and comments really enrich the discussion. But if you can't, the recordings of these sessions are made available after the fact on our Knowledge Exchange network. And if you've registered for this webinar, you will receive a link to that certainly by midday on Friday. We're excited about the next upcoming webinar on March 18th, when we'll hear from colleagues from Alberta Health Services for the Transition Navigator Trial, updates and lessons learned. The Transition Navigator Trial is an Alberta-wide, pragmatic, randomized control trial to evaluate the use of a patient navigator, comparing it to usual care and resources. Related to transition to support patients with chronic conditions who are moving from pediatric to adult health services. And if you have not already done so, please sign up for our Spark Live newsletter to stay up to date on all of our activities and events. So thank you for joining us today. Thanks to Children's Healthcare Canada member Alberta Children's Hospital and the Child Bright Network for supporting our webinar program. And hopefully we'll see many of you back here next week. Bye, everyone.